This is Augusta DeLomo on January 14th, 2025 at 4:02 p.m. in Washington, D.C., conducting an interview for the Global Oral History of PEPFAR project. To begin, could you start off by introducing yourself and establishing your connection to PEPFAR and what years you worked on PEPFAR?
Sure. Thank you. Good to meet you, Augusta. I'm Rebecca or Becky Bunnell. I am currently the Principal Deputy Global AIDS Coordinator here at the Bureau of Global Health Security and Diplomacy at State Department, and I am the second in command overseeing the PEPFAR program around the world. I have also had a long history of working on HIV/AIDS dating back to prior to PEPFAR in global work, initially in Uganda, starting in 1989.
And could you tell us a little bit about yourself and your family, where and when you were born and where you went to school, things like that?
It's fairly unremarkable in the beginning. Well, actually, that's not true. When I was very little, I was born in Ithaca, New York. I went with my parents and brother and lived in Indonesia as a very small child. That was my first language, actually, was Bahasa Indonesian. But then came back and grew up in Poughkeepsie, New York, which was fairly unremarkable. Went to public high school there. I went to Yale University for my undergrad, and then did the Peace Corps. And I was in Honduras. So I'm a RPCV, as we say, a Return Peace Corps volunteer. Do you want me to keep going?
Up to you.
Yeah, I mean, and subsequent to that, I worked for a while as a teacher in an inner city school in Boston. Then I went and did a master's in international, a Center for International Education. And there I started doing some work on HIV education. And after I finished my master's program, I went and worked in Uganda with Médecins Sans Frontières, MSF, on a community-based healthcare program after the war. And that's when I really dove deep into HIV work.
Can you tell us what it was about HIV that interests you specifically and what really drew you to dive more into this, as you said?
I initially got interested in it because I had a friend who was diagnosed with HIV here in the US. And then, of course, when I went to work in rural Uganda on community-based healthcare, HIV was everywhere. And it was a new and very disturbing, of course, horrifying thing for the nation. And it was impossible not to dive in if you were working in the healthcare field, or any field, actually, in those days in Uganda. The devastation from HIV was very profound.
How would you explain HIV to a layperson? And can you tell us, when you first started in this work, some of the misconceptions that you were dealing with when you first started working on HIV in this early period?
Yeah, I mean, I think there were a lot of misconceptions on, it's a virus, how is it transmitted, who can get it, misconceptions, which in some ways persist today, that people think, it's only for men who have sex with men, it's not for heterosexual or for children. So just misconceptions in understanding about the disease and the transmission. Over time, there have been all kinds of misconceptions. Misconceptions that it was planted by the U.S. or others in Africa. Misconceptions today that the problem is solved, that it's no longer a challenge for the world. It's no longer a global health threat, and so. I think throughout its history, there's been a lot of misconceptions about HIV. It's a complicated retrovirus.
It is.
Yes.
It is. And for someone who's worked on it as long as you have, as you said, you've really seen the arc of how we've come to understand the virus, understand what transmission looks like, and how treatment has evolved. And I'm curious, when you think about, when you get to Uganda and you see the epidemic, give us a sense of what the epidemic looked like in Uganda in those early years and the kind of work that you were doing initially, right at the start.
Well, after my first year in community-based healthcare, I went and worked for the first indigenous HIV organization in sub-Saharan Africa called TASO, or the AIDS Support Organization. Was started by a group of Ugandans who'd all been impacted by AIDS, either were themselves infected or their spouse had died from AIDS, et cetera. And they started as a kind of a support group, and then over time it grew, and up to today it's one of the major providers of HIV care, treatment, and prevention services in the world, certainly in Uganda. So early on, though, it was well before we had any treatment, didn't even have sort of basic preventive care options for folks. So I remember early on doing things like we were training community health workers. I think we trained over 2,000 across Uganda in just the basics of, you don't have to be afraid to touch somebody who has HIV. You don't have to be afraid to provide basic, treatment and care for a person. And having the opportunity to use pictures and stories to tell sort of, to help educate people about how HIV is transmitted, how it could, how you could be in a relationship and maybe not get HIV at one point in time, but get it later. So I remember we developed this story called Yokana Story, and it had these pictures, and it was like we made a storyboard. It became super popular. Everybody they kept talking about Yokana Story. And Yokana was a man, and he had a wife, and then they have children. And in the story, we just used simple symbols of red dots to symbolize HIV infection. And we showed the story of mother-to-child transmission, and how it did not happen for the first child, but it did happen for the second child in their family, and sort of used that storyboard all over the country at the village level to help people understand that it was kind of an invisible virus, but what could happen, and that it had a long time period where you would be asymptomatic and not realize that you had it. So I could tell you a lot of stories. I mean, there were lots of things that touched me personally, just working with a community and with an organization that was so focused on support for people living with AIDS. We generally had a burial or a funeral at least once every 2 weeks of one of the colleagues or somebody in the community that we were working with. So it was the 3 years I spent working with, well, first with MSF and then with TASO, were some of really deeply, profoundly touched me, because, you become close with people, and then you're working side by side trying to get these education out, and then they fall sick, and we really couldn't do anything much to help folks. So many, many people died during those years, and including some children who I, like to this day, there's a little girl named Priscilla. I remember her very vividly. We used to spend most of our weekends. I love children, and at the time I had none of my own, and so used to always take her. She had HIV, and used to take her every weekend. We would go, for somewhere to go swimming or get ice cream or do something special, and she died when she was 9. She actually lived a long time, but
it's striking to hear you talk about your work with TASO, and we heard about TASO earlier today. We spoke with Ambassador Kolker, who talked about the work and the community approach, especially at this early stage. As you said, there's no treatment. And so what you're really doing is prevention and education, and I'm curious how that experience, informed you when you get to the stage, and we'll get to that later, where there is treatment. But what did you learn in that stage where you're just trying to prevent the spread?
Yeah. Well, I think we were there were a couple things we learned. Uganda is very famous for some of the things that Uganda did early on in the response. The ABC approach, which I think you had some interest in talking about, was very prominent in Uganda. But in addition, there was an organization called the Philly Lutaya, I forget what the full name was, Philly Lutaya Club or something, initiative, I think it was called. Philly Lutaya was a very popular Ugandan singer who died of AIDS, but you should look him up because there's some beautiful videos of him at the end. I can send you a couple clips, but he really brought out into the open testifying to the world, I have HIV and I want to tell you about it and I want you to be careful. And that organization that bared his name trained people to be spokespersons. And so I remember working with that organization, and it included, everything from a young mother to, a major in the Army, to, a business person, and trained folks, people in the church, trained people to go out and speak at the community level. And that was fantastically, I think it was early on in Uganda, it really helped to deal with stigma and bring it out into the open. And people, some cases were shocked, like, oh my goodness, Augusta, you have HIV. And I'm not saying you do, but you have HIV, you look healthy. And Augusta, person would say, yes, I do have HIV, and let me tell you how you can keep yourself safe. And that was very important, I think, early on. The other thing early on, Museveni, the president who's still the president today, he spoke about HIV in every speech that he made for a number of years. He always brought it up. And I think that was really helpful, too, to have that political engagement.
And you leave Uganda in this, after your first experience with TASO in 1992, you work domestically with the CDC, the California Department of Public Health, you get your PhD, and then you come back to Uganda in 1999. And I'm curious what changes you noticed in that 7-year period of when you came back. What did you remember about the the state of the epidemic when you get there in 99? Did it feel different? Did it feel worse? What was the state when you arrived with the CDC then?
Yeah. Well, I had done my own dissertation research in Uganda in that period, so I was kind of following the story along. But one thing that I think was different was, prevalence had gone up even higher. And the impact on the economy, on life expectancy, on so many things was very evident by the time I went back. There were some initial investments that donors were making. There was the Life Initiative. There were some other things that were happening. So things were a little bit different. When I went back in 99, I was working with USAID as the senior advisor for HIV. And at that point, there were, it wasn't just TASO. There were a number of community organizations I know we worked with. I remember a faith-based network. We had a Muslim organization that was very prominent, a number of other church-based organizations that were very much engaged in the prevention work. And then there was a large testing initiative that had started, the AIDS Information Center, and I did a lot of work with them in the beginning. So there was counseling and testing available for people. All of that was newer. I mean, the expansion of it was much newer when I came back.
It's striking how you describe, the number of partners and players and organizations that at this point are involved, not just American, but others. And I'm curious, especially as in this period, you start at USAID and then transition to the CDC. Could you tell us a little bit about, what is the purview of USAID in an environment like this? And how does it differ from what the CDC is doing at this time?
Yeah. I think both organizations then and to this day, we're working in collaboration in the same area of funding local initiatives and trying to get things started. There was an innovative person, you should put her on your list if you don't have her, Elizabeth Marham, who worked at USAID as well for many years, and then later also worked with CDC, who I think had a good vision on funding indigenous organizations and really building their capacity. And so I remember USAID, we had an umbrella mechanism that funded a bunch of smaller local organizations and kind of, not just on technical things, but help them get their feet secure on, how do you have a board meeting and how do you write a grant application and sort of, organizational development things that really helped fuel, I think, a solid foundation of community service organizations that could work in that space. CDC was a little bit different, and I did transition after a bit over to work at CDC. CDC was working on, a lot of laboratory-based stuff, and then also doing some more kind of applied research. So not just programmatic work, but they also were working on applied research. And I was interested in that because I had done my dissertation on HIV in Uganda, and I was really interested in figuring out what more could we do. Can we build an evidence of what you could do, evidence base for what we could do? Even this is before we had antiretroviral treatment. And one of the things we worked on in those days was a basic care package, because I had seen time and time again, starting back when I lived in Luero in 1989, that basic care for people living with HIV was totally lacking. So A, people were afraid to engage with them, but B, we weren't dealing with health threats that are especially severe if you're immunocompromised. So making sure people have clean drinking water, making sure that they have mosquito netting to protect them from malaria, making sure, as we did this research, that they had access to things like cotrimoxazole prophylaxis, which is a simple, very cheap antibiotic that can prevent opportunistic infections, malaria and others, for people living with HIV. And so we did some of the initial kind of operational research, like how do you get that out to people? Will people adhere to it? What happens? And what was really interesting is that we found that not only did that basic care package help somebody living with HIV to have less, to live a more healthy life, it helped their children. It helped their whole household to have less infections and actually reduced mortality in their own children. Not because the children were getting sick from HIV, but because they weren't getting these other infections that sometimes someone who was immunocompromised would bring into the household or spread. So that kind of got me hooked. And then when we got antiretroviral treatment opportunity to bring it to Uganda, we continued to build on that platform of sort of community-based operational research that we were doing in conjunction with TASO, actually, in eastern Uganda, in a rural area. And we had the first 1,000 people to get on antiretroviral treatment basically in sub-Saharan Africa that weren't in a rich facility-based kind of setting. These were people really in the village.
It's really striking when you talk about the applied research component and how much of this work, the basic care package, understanding, what works with couples, and that's happening as separately the Bush administration is thinking about PEPFAR. And we heard from Ambassador Kolker and others that you start getting requests for people to come visit. Mark Dybul shows up and he wants to learn about treatment, and particularly outside the cities. And so can you tell us a little bit about when you started to hear the rumblings about something like PEPFAR and Bush people started showing up, what that was like as someone who's on the ground, working and running these studies? Yeah.
I mean, it was, an extraordinary experience to be able, my heart was so full of wanting to make sure that we could do everything we could for people living with HIV, because I'd seen so many people who were dear to me, die. And, when we started doing the work actually with antiretroviral treatment, and there was this, Lazarus effect for people, CD4 count of 4, then recovering and being able to be vibrant members of society, the CD4 count, up to 1,000, and, they're doing great. showing and being able to demonstrate that this can happen, this can work, even in this setting, even in the, we were in Truro district in literally like rural areas. And I remember when Secretary Tommy Thompson brought a whole delegation, there was 100 people on the delegation out to see this. This was after Mark Dybel and others had been there multiple times. They said, oh, no, we've got to, Bill Steiger, others had come, and they said, oh, we've got to bring a delegation out to see this. I don't know how long we have. I could tell you a lot of funny stories about how that whole big trip went. But the bottom line was we had a delegation of 100 leaders from the U.S. It included, members of Congress. The head of Tony Fauci was there. The head of major businesses, and pharma companies, leadership from HHS, et cetera. There was a big delegation of kind of key stakeholders. And they came, and per Bill Steiger, I'll give him total credit for this, he's like, no, we got to take them out. And each of them has to do a home visit in rural Uganda. So the logistics were
insane,
taxing. We had to bring buses from Tanzania because we didn't have a bus in Uganda that could function to take people out. But we took them out. We finally orchestrated this visit. And I think they were just flabbergasted because here were people in the poorest of poor who were successfully on treatment, whose lives had been transformed. And I remember Tony Fauci giving a press interview when we brought everybody back. We were in Entebbe. And at the time there'd been, I won't name the person, but there'd been somebody high up in government who'd said, well, we can't take antiretroviral treatment to Africa because people don't even know what time it is. How will they adhere to their treatment? And I remember Tony Fauci, or I was either Tony Fauci or Secretary Thompson saying, I've just visited a woman named Rosa. And not only did Rosa know what time it was, she knew her CD4 count. And she has successfully adhered on treatment, and we can do this in Africa. And I think that moment was very exciting because I think everybody saw this can be done. And it kind of coincided with PEPFAR really taking off and people really endorsing it. So, we were thrilled when PEPFAR was announced, completely thrilled. And I remember Ambassador Tobias, who was the first head of PEPFAR, I remember we had a meeting several months after PEPFAR had been, launched, and we were each supposed to present like what we'd done and where we were. And I remember, not that I want to brag, but I felt very proud because we had one slide that Ambassador Tobias pulled out from all the countries who had come to this meeting in South Africa. And he said, this is my favorite slide of the whole meeting. And it was a slide we'd made that basically showed the backdrop of a community. This wasn't the same community. Now, this was in Kampala in a slum setting. And we had said 42 days. And it was 42 days after Congress had signed the authorization for PEPFAR. We got treatment into that community in 42 days. And he was so happy with that slide because we had worked super hard. When we heard PEPFAR was coming, we were so excited. All the community organizations, everybody was so excited. We were getting ready, and as soon as the funding came, we were like, okay, we're going to get this out. We're going to sign the agreements. We're going to make sure we can get treatment out to people as quickly as possible. Because literally, people were on the edge of dying, and if they could get access to the treatment, they were going to live. And so we were like, we don't have a minute to waste. So that was very exhilarating.
It's startling to hear, you talk about in other interviewees, how quickly you all were able to actually implement PEPFAR. Mm-hmm. And I'm curious if you could tell us a little bit about, in my mind, you're here, the State of the Union, and it's boots on the ground and we're going. And I'm curious what did that scaling up look like, that 42 days? What were the things that you all were doing in Uganda in that in-between time? What were you building on, and how were you trying to get everybody up to capacity to get these ARTs going as quickly as possible?
There were we were sort of fortunate because we'd been doing this operational research. So we'd already worked through some of the things like the counseling protocols, like how do you sit down and talk to somebody? What are going to be the issues about adherence? How do you talk to them about that? How do you talk to them, about the need to continue prevention even when you're on treatment, et cetera, et cetera. So we had some of that ready, but we had to kind of convert it into training for local providers, setting up the laboratory mechanism, laboratory capacities to do, baseline testing for folks and to do monitoring over time. Of course, there were a lot of administrative and management things of, how do we fund organizations that can do this work? And we went through some of the sort of shortcut methods of doing that for the first set of organizations to get them going, and then later got them into what still exists today, which is sort of more of the bigger PEPFAR infrastructure.
And I believe your title at this time is Associate Director of Science. And there's a real research component, as you've described, the care package, understanding how to talk to people about treatment, what it meant to adhere to a protocol. And I love to talk about some of those things that you all found from your research that were especially applicable in Uganda. We've heard a lot about why is counseling and testing important? For a layperson that's never, learned anything about HIV, why is that such a critical piece of this puzzle?
Well, I mean, up to today, knowing knowing your HIV status is really the entry point into prevention or treatment and prevention. So, if I don't know whether I have HIV or not, if I don't have HIV, I will continue to protect myself, hopefully. And if I do have HIV, just learning how I can get access to treatment it's absolutely critical. And one of the things, you alluded to sort of, I think some of the work that I and colleagues did looking at the importance of working with not just individuals, but working with couples and working with households. It's one of the things I still feel like we may have lost track of that a little bit today in our response, that if I have HIV, I really should know what my husband or partner's status is. And I really should know what my children's status is. And, a household intervention, or today we call it more index testing, but making sure that everybody that I've, in my community has had that opportunity to be tested is really important. Because there can be a fair number of people who are in discordant couples where one person has HIV and the other person doesn't yet have it. Obviously, they're at very high risk of transmitting it. And B, there could be children who have undiagnosed HIV infection, or women who don't realize they have HIV and should, take precautions if they're going to get pregnant to make sure that they don't have mother-to-child transmission. So it's such an important entry point for testing.
It was striking when I was reading through some of the things that you all worked on and reading about women who were trying to get pregnant and who were navigating, a partner that had HIV and what that meant. And I remember thinking, you read a lot about mother-to-child transmission, you hear about the ABCs, and that really stood out to me as, that's the kind of work that you all are trying to do. And I was thinking about the work that you did with Tasso of how do you live with HIV? And I'm curious, that experience of working with mothers and children, that's such a huge piece of how PEPFAR gets passed, and some of the things that you saw on the ground in that part of the work.
Yeah. I mean, in Uganda and perhaps in many places in the world, having a child is very important culturally and personally. I remember early on, there was a young girl, she's about 16, who was at Tasso as one of the clients, one of the people living with HIV. And I can see her now as we're talking, but the poor woman had herpes zoster all over kind of her face and going down her neck. So she's got this very painful, horrible rash. And it's like shingles, we call it shingles, but it can be an opportunistic infection. And she had acquired HIV because she had been raped by several members of the Army. And it was just a tragic story, young woman. And I remember talking with her, and she's like, I don't mind that I'm dying myself, but to die without having had a child, I feel like I never existed. And that I still remember that quote today, because it just was like, wow, that's a very profound statement. So very strong desire to have children, but obviously getting out prevention of mother-to-child transmission services to people is super important in that context.
How do you see or what do you remember trying to navigate at this time of, I'm thinking about the money is flooding in, right? We now have funding for antiretrovirals, but at the same time, you all are also doing all this research to think about prevention, risk behavior. You're doing all this simultaneously. I don't know how you all found the time, but what is it like navigating those different priorities and recognizing, PEPFAR has a mandate that they want a certain amount of medication, they want to see that it's being used, they want to see that it's working. How do you balance all those things?
I'm a scientist, but I've always been very, very applied in the work I've done. Like, it's not about, I haven't been a bench scientist, like doing something theoretical. It was always about doing applied work that tells us, are we doing the program in the right way? Should we have different counseling messages? Should we be, tweaking something, different ways of service delivery to make sure that our program will work better? So it was a little bit more like evaluating what are the ways to do things in the best ways. So I found it a really nice combination to be able to both do the programmatic work and continually improve it and make it better and generate the evidence for more impact at the same time. It appealed to me to do those things. But there were a lot of late nights.
I bet, yeah. There was a paper that you wrote that the title stood out to me it was called It Ends With Me, talking about Ugandan responses to HIV and AIDS. And you've mentioned the president, and I'd love for you to talk about, Ugandans you worked with that, whether it was people that you were interacting with in a clinical setting, whether it was local leaders that you remember their investment in the things that they wanted to see coming out of PEPFAR that were things that you all prioritize based on, this is what we're hearing on the ground, this is what people want.
Yeah. I mean, I think, the number one priority was to stop people from dying and to make sure that, people living with HIV could get access to treatment. And that was sort of the genesis. And that was absolutely a big motivation right from the beginning. I did get involved, and I worked on one of the, I think, very first studies that documented that actually when you take treatment, that is the best prevention. It wasn't a randomized trial, it was an observational study, but we showed that in discordant couples, in that first group of 1,000 households that I mentioned, that when people had access to antiretroviral treatment, there were no transmissions within discordant couples, and there was a 95% reduction in transmission, or 96% reduction in transmission from what would have been expected had they not had treatment access. And then subsequent to that, there were a bunch of very highly funded trials that showed the same number, 96% reduction. So I think realizing early on that actually treatment is prevention too. And there's primary prevention that's also important, but treatment is the most important way to stop the spread of the virus because it stops circulation of the virus. So, if you have any other infectious disease, if I have TB, we always start in, basic infectious disease control, you always start with the source, like the person who has the pathogen so that they don't transmit it. And somehow in HIV, I think we've lost our way sometimes because we dichotomize like treatment and prevention, and actually they're much more interconnected. Yeah.
I think that's been one of the most striking things as we've talked to more people about, even just from a comorbidity perspective that, and you mentioned the woman that, was suffering from other STDs that had taken advantage of the reduced immune system that that kind of holistic approach that you're describing. It can't just be a focus on medication alone. It's understanding all these other pieces. After you're in Uganda, you move on to Kenya, still with the CDC, as the director of global HIV/AIDS. What pushed this role? What were you interested in? Why did you go there next?
Partly family considerations, but it was an opportunity for me to now oversee the entire portfolio of programs. So I was then the director. I was overseeing the care and treatment, the prevention, the laboratory, I can't remember all the different, the special populations, all components of it. And so I was excited about that. I was also excited, to learn from people in a new setting, but also to bring some of what we'd learned in Uganda, into Kenya, which, Kenya's at the time especially was, even today, a wealthier country. There was more trained people, more infrastructure, et cetera. But in many ways at that time, Uganda was kind of ahead, particularly in certain areas like pediatric HIV interventions and some of this openness about HIV. Uganda was a bit ahead. So it was interesting to come to Kenya where I was like, okay, they've got more going on here in terms of trained people, infrastructure, et cetera. But in some ways they had more to learn as well. So that was interesting, yeah.
Especially when you think about, when you're in Uganda, you are pre-PEPFAR and in PEPFAR. And when you get to Kenya, PEPFAR's already been in place. And so what were the things that PEPFAR was, in your mind, already kind of successfully doing when you got there? And what were the areas where you said, okay, this is where we really want to focus?
I think when I got there, where treatment had started to scale up in Kenya was all very much facility-based. And so I definitely saw an opportunity for us to do more disseminated service delivery models and get more into community and sort of working not just with the Ministry of Health, but also working with local organizations more. And then the other striking thing was the pediatric arena, that there was a lot of children in Kenya that were not being diagnosed, not being treated, and prevention of mother-to-child transmission programs needed a lot of emphasis. So I did a lot of work in that area. We also conducted the first sort of robust, I think today we call them FIAs, but the first kind of, at that time we called it KAIS, the Kenya AIDS Indicator Survey, but essentially a FIA survey, so a national survey of HIV in Kenya that was exciting because we had, nationally representative data, and we did a lot of work in not only having participatory sort of interpretation and analysis of that data with key stakeholders. We also brought in some economists who helped us look at, okay, given all these data that we know, like where infections are, and given what we know about various interventions, what is going to be the most cost-effective and impactful way for Kenya to spend their resources to prevent HIV and to fuel the response. So out of that, one thing that came out very clearly was the role of voluntary medicalized male circumcision. And Kenya, based on those engagements, Kenya ended up working ahead of the game in that area, working with Peter Cherichik, who was at the Ministry of Health at the time, worked with me, and we worked with WHO. Kenya wrote their guidance before WHO even got theirs finished. And so as soon as WHO's came out, Kenya put their guidelines out, and Kenya was ready to go and scaled up VMMC programming in Western Kenya, where the epidemic was the worst and where many men are not circumcised. And that, I think, was very exciting and impactful. So those were sort of some of the things I focused on while I was there.
What would you say, one of the things that was really striking when we heard about Uganda from you and also from Ambassador Kolker is there's this really great landscape of partners that you all had. And so I'd love to hear about some of the partners that you had in Kenya, some of the stakeholders, as you referenced, that were your primary point people, your big allies as you're trying to get some of these things in place.
I mean, there were a number of great partners in Kenya for sure as well. We had, I'm trying to remember the exact names, but there was a Lutheran program, there was a Coptic church program, there was University of Maryland, I think Bob Redfield was involved in that program. We had Catholic Relief Services, we had, I think perhaps fewer indigenous Kenyan organizations than in Uganda, at least initially, but they were growing up. We worked a lot with the Ministry of Health and other ministry that were joined to that. We did some work on nurses with I forget which ministry it was, but the one that oversees staffing and personnel. So we had a lot of good organizations. I can get you a full list. I can't remember them all.
It's great to hear about the range. And one of the things that's really striking is we've heard a lot about the faith-based implementing partner component, and talking with various people involved in PEPFAR and saying, these are the partners, these are the people that, are on the ground that they're coming to. But, we've also heard a lot about they weren't the only partners. And I'd love for you to hear about, for Kenya, what was the role that you saw a lot of your faith-based partners playing, versus some of the other people that you mentioned that you worked with?
I think the faith-based, were able to, they just have a really important entree into at the community level, into people being able to trust them, and I think, and have a forum where you can talk about everything from, who do you marry to issues around children, et cetera. That was super important. And they have literally the pulpit, in whatever form to reach out to folks. So that was really important. We also did have in Kenya some strong academic partners. I know the University of Washington from Seattle, there was Connie Callum, King Combs, some of the sort of prominent folks there did a lot of work in Kenya and actually trained a lot of senior Kenyans. That was very helpful as well.
When you're in Kenya, you go through a presidential transition as well, right? You go from, are you in the Obama years when you're in Kenya?
Yes, in the beginning, yes. Yeah. In fact, I was there when the election happened.
Wow. Yeah. And we've talked to a few people who have been in the sort of Bush-Obama transition with PEPFAR, and I'm curious if there were things that you felt there were changes coming, or you thought, actually there's a lot more continuity than there is change in their approaches to PEPFAR versus the Bush administration's vision for the program.
So I remember Obama came and Michelle came to Kenya. Bush came when I was in Uganda too, but I'll say Obama came when he was a senator. So this is before he became president. And I remember that we made sure that we featured him in a PEPFAR setting as part of his itinerary. So he went out to Western Kenya, where his grandmother lives, actually, or lived. I think she's now passed, but lived. And while he was out there, he and Michelle had couples counseling and testing together. And we used that. We had photos. We used that, and then later when he became president, we used it more. But we did that in part because we wanted to make sure that Bush's legacy wouldn't end with him, that they would feel engaged. And I think that, I never talked to him about that, but I think that, that experience of being tested with Michelle in, Western Kenya in a little kiosk thing, it's probably something they remembered, and they realized the importance of that. And so, we were trying to make sure that there would be bipartisan support as that transition happened, and that there'd be continuity. I do remember him asking, is there something else I could work on in addition to HIV to kind of, have my signature on something. I do remember we said, well, keep the HIV going, but you could choose another thing, like maybe malaria. So but my sense was it would be hard to go to any country and not realize the importance of HIV at that time,
I'm repeatedly struck by just the personal way, whether it's people who are working in HIV, but really showed policymakers, stakeholders, the real impact of this kind of work and the importance of that buy-in when you think about the reauthorizations and how so many members of Congress across the political spectrum have gone to clinics and seen things. It feels like such a huge piece. And you're in Kenya for, I believe, 3 years. And when you look back on that, what are some of the things that you're most proud of from that time?
I think we continued to do a rapid scale up on the whole PEPFAR program, so across prevention, treatment. We established a much more robust national reference laboratory, which was really important for the response. We did the male circumcision work that I mentioned, and then the national survey, I think, was really important. Those are some of the major things that jump out to me. I think having, this is not a headline thing maybe, but I think having the opportunity to really engage the Kenyan, both the ministry folks, the AIDS control program, the National AIDS Control Program, and other stakeholders in the discussions I mentioned about, like, here's your data, what does that data mean? And if we think about it, here's how much money Kenya has available to them. How can we use that money most effectively? So that probably didn't get a lot of headlines, but to me that was a really important thing. And I'm proud of that because it's sort of one of the key principles that PEPFAR has, is that use data to help inform action. And that was a place where the stars aligned and we were able to really, I think, mobilize the most impactful use of the resources Kenya had.
And it seems like it was such a driver, especially for the Bush administration folks, of why they wanted to do PEPFAR the way that it did, and being able to provide the data to say, these are our numbers, this is where it's working, and this is how we can continue to be cost effective. Ambassador Coulter told us that people from the Bush administration were shocked when he said, this costs $30, right? That having that data to say, this is how we can spend this money effectively. I imagine it was just as effective in your meetings with, the Kenyan authorities of this is what we can do with that. Can you tell us a little bit about, what kinds of things they were interested in, maybe in ways that were different than the kind of things that you were, sending up the chain to our people on the U.S. side of, what were the things that they wanted to see at that stage?
I think PEPFAR from the beginning, and certainly today, we've always had to make hard choices, and one of the good things about PEPFAR is it's been very inclusive, and it's brought in, it's had a big tent. It bring in all the stakeholders. We talk about it together. We figure out the ways. But under that tent, you have to make some hard choices. And I think I remember particularly the head of the National AIDS Control Program, he was getting a lot of calls from all the different community service organizations. They all wanted to be funded and couldn't fund them all. Right? And not all of them were doing work that maybe was that impactful. So there was a tension between how much do you fund something like, the more clinical approaches, and how much do you fund the community approaches. And there was even a divide between the Ministry of Health, which was like, we have to do male circumcision. That's the most impactful thing. And the National AIDS Control Program, who said, no, we just need to fund community organizations, and that will be the most effective thing. And so I think there was that divide. Because I have done both behavioral science work and epidemiology, I sort of find myself always in the middle of on that. But I think there's a happy medium where you can bring in the best from both sides, and that's the way I personally have tried to operate in my own career.
When you're thinking about, the implementation piece, and I'm struck by, you've done so much work on the ground. You've spent so much time, whether it was in Uganda or Kenya. You spend 4 years working on anti-smoking advocacy, and then in 2015 you come back to sort of global public health. And I'm curious how these experiences inform the way you think about the U.S. role in the world in global public health? I know one of the early justifications the Bush administration used for why PEPFAR is it was a national security imperative, and that this was something that made the U.S. safer as it made the rest of the world safer. And I'm curious how you started to think about those kinds of things, bringing in the experiences that you had working in Africa for, however many years.
Yeah. So, as you noted, when I came back to the U.S., I spent a number of years working domestically on community health care and other chronic disease things, which was very interesting domestically. And I did that partly for family reasons. My children were at a stage where I wanted not to be, traveling. But in 2015 it was, when the Ebola outbreak happened in West Africa. Across CDC, they're like, Becky, you were in Africa for 14 years. You need to come over and help with Ebola. And so I ended up being shipped out to Sierra Leone on assignment for several times. I went for 6-week periods during the Ebola outbreak. And I was like, oh my God. I went out there sort of a little bit like proud of myself, like, oh, I've done this before. I know what I'm doing.
This is not my first rodeo.
There are other people who'd never been to Africa. And I was like, oh, I got this. I was completely humbled immediately when I got there. And I was like, oh my God, I've never experienced something like an acute Ebola outbreak in Sierra Leone. It was just, and people infected and dead in 8 days. In Uganda, it was like 8 years or 10 years you had with HIV, and suddenly it was such a different thing. So I was humbled, but I also learned a lot. But I realized a lot of the parallels in terms of what is a global health security threat. HIV, absolutely, as you said, it was the first one named by the UN Security Council as a health threat, as a global health, as a security threat, the first disease named as a security threat. By the time I went and worked on Ebola, I was like, yeah, there's no question that this is, a health security threat. So that kind of threaded my life back together. And then, yeah.
It's mostly a futuristic question in terms of PEPFAR's strategic direction going forward. We have heard a lot that the success of PEPFAR learned from what was happening in Uganda, and the successes primarily coming from a very strong community-based response.
Yes.
So we moved into an era where now, drugs are so effective, and that's primarily where most of the resources are directed. Mm-hmm. I just want to find out, we live in a world where we're not going to have certain amount of resources going forward, and I'm happy that you are in the fence of science and behavioral sciences as well. So what do you think is the future? Are we going to keep going with the tangent of biomedical medicine, which is great for people that have HIV already? They need to be on treatment. But there's new young people that are being born, and there are people that are not infected. So, how are we managing that to make sure that we are not just saying biomedicine is the prevention, to keep the other people from being infected, and the type of resources that will go in with that to make sure that we are striking the balance? We don't just say people should be infected and we treat them. So that's just the strategic direction.
No, it's a great question. And, I'm thinking about sort of where we are in PEPFAR in terms of, our partner countries and other partners and PEPFAR together, we've made great progress in, bringing down rates of infection, making sure as many people as we can have treatment, et cetera. But we're not there yet, and so we've made progress, but we don't want to confuse progress with success. We haven't been fully successful. So I think what you're bringing up is super important, is that to be fully successful, we've got to bring down incidence and new infections. And we also need to do that if this is to be sustainable over the long term. There's no way we can get to sustainability unless we can stop incidence or bring it way down even further than where we are. So, there's a lot of excitement right now about lenacapavir, which is a new long-acting injectable preventive agent. So if I get lenacapavir, I am protected from acquiring HIV for a 6-month period. And there's research happening now that might extend that to a year. So it's another biomedical intervention, which is very promising, can be a game changer, but it doesn't work in isolation. Lenacapavir will not work unless we do pay attention to the behavioral issues, to the context, to the community issues that surround it. So if I have one injection and I never go back for the follow-up, if my community stigmatizes me because I went for the injection, then there'll be no demand for it. We have to pay attention to the behavioral, the community context, or even the best, that's like one of the best biomedical interventions we've had in a long time, but it won't be successful unless we look at it in that context of the community, the behavior, a person-centered approach that will get us to where we need to go. And that's exactly what we're trying to do with PEPFAR and the way we're approaching lenacapavir as an example.
I am conscious that we have 1 minute. And so with my last minute, I want to know, I'll say personally, my PhD is in history. It was in U.S. foreign policy, and I really learned nothing about PEPFAR until I started working on this project. So if you were talking to, a regular American sitting here, also me, what do you want them to know about PEPFAR, especially conscious of the fact that, reauthorization is coming up soon. So what do you want them to know about the program?
I think PEPFAR is one of the most extraordinary investments in history in global health. We've saved now 28 million lives. We have averted HIV infection for 7.8 million babies. We've had huge impact. It's incredibly cost effective in terms of the return on investment has been enormous, not just in that area, but you look at what's happened with the number of kids in school, the economies of our partner countries, et cetera. The investments have led to all kinds of benefits. It's also helped the U.S. in all kinds of ways. President Bush is revered in sub-Saharan Africa. You go into those homes in rural Uganda, they have photos of him on the wall. They remember that he started PEPFAR. And it's not just about him. It's about, everybody knows PEPFAR. They know what PEPFAR is because, as the president of Botswana said to me and the ambassador recently, when we were there for a visit, you saved our country from extinction. But he also said, I'm sorry, I'm wandering a little bit, but he also said, but we also know that a good friend can't be a friend forever and can't take over the work that the people of a country need to do themselves. And from there, we went into a whole discussion on sustainability and self-reliance and how it's super important for Botswana to be able to own and run that program themselves going forward. So I think for PEPFAR, we've almost reached the top of that first huge challenge of climbing to the mountaintop of getting the epidemic under control. Our next mountain is really to conquer the sustainability and the self-reliance. So I think if we can, PEPFAR has shown that concentrated investment, huge partnership approach, engagement of people at the community level to top political leaders, and dedicated resources from the U.S. can be extraordinarily impactful.